We have a fantastic talk today that's called Aging with HIV, Geriatric Cases from the Golden Compass program at Ward 86. And we have three fantastic speakers. Our first speaker is Dr. Meredith Mirrer. Dr. Mirrer is an assistant professor in the Department of Family and Community Medicine. And Dr. Mirrer is a geriatrician and sees patients at the Golden Compass program at our clinic at Ward 86. The next speaker will be Emily Heinzen. Emily Heinzen is a staff attorney at the AIDS Legal Referral Panel and has been with that organization for 8 years. And then after that, Dr. Chodos will speak. Dr. Chodos is a professor of medicine in both the Division of General Internal Medicine and Zuckerberg San Francisco General, as well as the Division of Geriatrics and the Director of Whole Person Geriatrics for the San Francisco Health Network. We are excited to have them come and speak today, and I'm sure it'll be a fantastic talk where we'll learn a lot. So thank you to all of you.
Thank you so much. Thanks for that wonderful introduction. I'm Meredith. I'll go ahead and get started. It's been a real honor to work with your teams and work with your patients this past year or so. So I'm going to be sharing a couple of cases of patients that I've seen recently and highlighting some of the resources that we're able to engage with. So thank you so much. I have no financial disclosures to report. So our main objectives for today are to understand fundamentals of advanced care planning, a really big topic, as well as some of the common geriatric syndromes and symptoms in older adults living with HIV. Goal to identify one way to improve your care for older patients living with HIV, as well as to connect with resources for advanced care planning and for caring for older adults with diverse needs. So our first case is a 67-year-old with a history of HIV, sensorineural hearing loss, hypertension, peripheral neuropathy, insomnia, and cognitive impairment, who initially presented to clinic for the evaluation of memory problems. In reviewing his functional status, he does receive assistance with shopping, housekeeping, and sometimes bathing and dressing from his in-home supportive services worker, IHSS worker. And that's really related to his challenges with mobility, some of his physical symptoms and physical mobility. He does continue to manage his medications and finances independently and without concerns. Reviewing his other symptoms, he did note insomnia. He told me he wakes up in the middle of the night, usually around 3 in the morning, and then he usually goes to bed pretty early in the evening, around 9 p.m. after taking medication to help him sleep at 7. Reviewed his medications. He does take quetiapine for insomnia or Seroquel, and also is taking baclofen for muscle pain at that time. So we've had a lot of education previously, and we'll share some more in a later case about some of the unique challenges with medication management among older adults, especially those with cognitive symptoms. He was really fortunate to meet with one of the Ward 86 pharmacists to work on reducing some of these medications with known side effects on the central nervous system, responsible for symptoms of drowsiness, sometimes confusion, as well as increasing his risk of falls. Because he was really only on this antipsychotic quetiapine for insomnia and really for no other psychiatric indication, he decided to stop it and was pursuing a gradual dose reduction of baclofen for continuing to manage his muscle pain. As part of his evaluation for cognitive impairment, he did go on to have an MRI of his brain, which did show some evidence of cerebrovascular disease, some potential small subacute infarcts, as well as white matter intensities, which we could see in people with HIV. I saw him again this year for a follow-up visit. He was really proud of himself for having been able to stop taking medication for sleep and was gradually reducing his baclofen. His cognitive symptoms were stable. At this point, we had diagnosed him with mild neurocognitive disorder, what we used to call mild cognitive impairment. And this subsequent visit, we really focused on talking about advanced care planning. So he had told me as an opening that his brother was quite sick in the hospital and several of his relatives had recently died, including his emergency contact. And he had not updated anyone in the clinic about this information. He'd never completed an advance directive. Okay, so for our first question, approximately what percentage of adults have completed any type of advance directive? Okay, so a lot of people said 5%, but actually the answer is 30%. So slightly better than we thought. And again, this is for adults of, a wide range of ages from the US. This was from a study from the range of 2011 to 2016. So, slightly older data, but it was about 30%. But clearly we're not really close to the majority of patients having completed this. Thanks for that. So what is advanced care planning? So this is the process of preparing for future decisions about medical care, preparing for future financial and long-term care needs, and naming decision makers. So this is a place where someone can communicate their goals and preferences about medical treatment, really indicate what matters the most to them in planning for the future, but also being able to complete legal documents that hold up regardless of whether they're here in the hospital or in our clinics or in another location, and really is really valuable for them now and in the future. So this is something I'm trying to prioritize with all of the patients I'm seeing, and want to be able to encourage all of you who are also seeing patients to participate in these conversations. I think, this is such a critical opportunity to be able to have conversations with our patients and connect them with resources to be able to make sure that their voice is heard, even when they can't speak for themselves. So when I'm talking about advanced care planning, I always start with naming a decision maker and trying to identify who's in someone's life, who can be their voice if they're no longer able to communicate their decisions for themselves, and also capturing, of course, goals that they have and certain values that help guide treatment decisions. But just to acknowledge, there are a lot of barriers to doing this, and I'm sure as primary care providers and even in other settings, time is often a huge barrier to having these conversations. And of course, they can be difficult conversations. There was a study in a population of adults with HIV. This was in Baltimore, Maryland, the Affirm Care study, who looked at relationships between different factors and the increased likelihood of advanced care planning discussions. So they found that higher levels of chronic pain, better physician-patient relationships, and effective family communication were all associated with increased likelihood of these advanced care planning discussions. So just to review some of the key components. So one of the first steps to think about is choosing a surrogate, and of course, asking that potential surrogate decision maker whether they could speak on one's behalf regarding, for instance, their medical treatment, or, as we'll discuss later, financial matters. Clarifying patient values about the outcomes of treatments. And a third factor to consider is establishing leeway or allowing for some flexibility in the surrogate's decision making. So documentation is another really important part of advanced care planning. So in this healthcare setting here in clinic or in the hospital, we have the ability to record information in the medical chart. So we can document the name and contact information for surrogate decision makers here in Epic or wherever your medical record system is, and update their contact information also in the chart. We can use specific notes to preserve that information in easy to access places, and also include information about patient goals and values. these notes can be really helpful to other people who are seeing the patient. So whether that's, for instance, they've come into the emergency room or they're in a subspecialty practice, those documents and notes from other care providers can be really useful when trying to make future decisions. Another thing that we can do is make sure that written copies of advanced directives, POLS, or other important legal documents are also saved into our records so that, again, that information can be communicated across time and across settings. Just to provide a brief example, in our local medical record, you do have the ability to add a healthcare agent. I'm not sure this works. So down here, you can, when you click on the patient's identifying information on the sort of left-hand side of their chart, you can go down and click into that field and add a healthcare agent. So for instance, you can name the patient's relative or friend and indicate that they verbally designated that that person can serve as a surrogate decision maker for their medical decisions and provide their contact information. Then at the sort of a lower portion of this same tab in the chart, there's a section where all of the advanced care planning notes that have been documented for that patient will show up. So just as an example, any conversation, whether it's in clinic or in the hospital or doing an admission or in the emergency room, those can all be preserved and then reviewed. Okay. Our second question, can people with cognitive impairment or dementia participate in advanced care planning? So yes, no. People with cognitive impairment can participate, but not those with dementia. Or D, it depends. Great. I see a lot of D's, and I think also some other responses. I think the answer that I was looking for was yes, it depends. So you do have to assess someone's decisional capacity in the moment to make sure that they understand and appreciate the decision that they're making, and that they can communicate a clear choice. So this is sort of the basis for informed consent. And regardless of whether someone has a diagnosis of dementia or a mental health disorder, for example, they may still retain capacity to engage in individual decisions about their future care or surrogate decision making. Right. I'm going to turn it over to Emily Heinzen to speak more about sort of the legal matters related to advanced care planning, and in particular, advanced care planning as it relates to finances, which is a huge area that we're so fortunate to be able to have services for our patients to help support them so that they can access resources that they need to in the future.
Sorry about that. Good morning. Thank you all for having me. My name is Emily Heinzen. I'm a staff attorney at the AIDS Legal Referral Panel. For those who may be unfamiliar with our organization, ALRP was started over 40 years ago in response to the AIDS crisis. So we had a panel of 4 attorneys going out to hospitals and homes to ensure that folks who were very, very sick were able to pass away with dignity and have their advanced planning documents in place. So fortunately, as HIV and AIDS and that kind of care has changed, so have the services that we as an organization offer. So again, since 1983, we have handled almost 98,000 legal matters for people living with HIV and AIDS. All the services that we provide in-house are free of cost. If we refer a client or a patient out to a panel attorney, somebody who supports our clients in a private matter, they are given a very low cost or reduced fee for the services that need to be provided. But in-house, we provide services in fair housing, eviction defense, immigration support, and the practice area that I practice in, estate planning, which is why I'm here today. So what I want to talk about a little bit more in touching on kind of what Meredith discussed is powers of attorney. Now, a power of attorney can be called durable powers of attorney, springing powers of attorney, but essentially it's a document much like an advanced healthcare directive, but it relates to finances and legal matters. So in short, it allows a person, which we will refer to as a principal, to state instructions about financial and legal matters and appoint an agent to act on their behalf if they're unable to handle their affairs on their own. But in short, it kind of allows the principal to put safeguards in place to make sure that if they are unable to make a decision, if they're unable to get to their bank, if they're unable to contact Social Security, it lets the agent step in on the principal's behalf to provide that kind of support. Now, one thing I try to emphasize with clients who I meet with, if you have a long-term partner, or if you have a really close family member, a chosen family member, so a friend, but there's no legal relationship that might normally allow them to step in on your behalf, a power of attorney allows you to appoint that person to step in and act for you. And so if people have long-term partnerships, but they're not registered domestic partners or legally married, this would allow that partner to step in and support their partner in financial and legal situations. Now, who can make a power of attorney? Any adult over the age of 18 who is of sound mind can execute a power of attorney. Now, a power of attorney is slightly different than an advanced healthcare directive or even a will in the capacity requirements. So an advanced healthcare directive and a will require what they call testamentary capacity, which means you know who you are, you know the date, you know your family, you know kind of your stuff. A power of attorney requires what they call contractual capacity, which is a higher level of capacity. So if that person is aware of the decisions that they're making, they're aware of the ramifications of those decisions, they're kind of aware of the ripple effects of the choices that they are making on their finances, on legal decisions. And so it's a higher level threshold. Now, it is something that, you know, when I as an attorney will meet with a client in the office, it's usually a little bit easier to assess capacity because they had the wherewithal to get themselves to my office, come in for the appointment, we'll have a discussion. Now, I'll talk a little bit more about it here in a few minutes, but I've come out to the hospital here to do these documents. And so that usually requires that I speak with the doctor. What kind of medication are they on? How are they interacting with you? How are they interacting with me? And if I feel any shade of doubt, because of my ethical responsibilities as a lawyer, I'll either call in a coworker to come meet with me and make sure that we're all on the same page about the capacity level, or I will put a pause and I'll try to come back the next day when maybe the patient's a little bit more with it, or they're on a lower dose of medication. But they must have a higher level of capacity to execute a power of attorney. Another thing that I often hear with clients is, well, I don't need a financial power of attorney. I don't have that much money. Asset amount is completely irrelevant. If you have any money anywhere, if you receive Social Security, if you have to file your taxes, if you don't have to file your taxes, if you have a bank account, no matter how big or how small, having a power of attorney is incredibly helpful. Now, how should someone complete a power of attorney? Ideally with a lawyer, because we're equipped to do this. We have the tools and the ability to execute these on behalf of your patients. But there are forms available online. There are probate codes that kind of explain how a power of attorney needs to be completed. But essentially, it's a competent person over the age of 18 who has the proper contractual capacity. They're able to name an agent in a document, and I'll come back to that in a second. It includes their name, the principal's name, their signature, the date that the document was executed, and it is signed in front of a notary public. So I'm a notary, there's another notary on staff, so we're sort of a one-stop shop. If you need to send a patient to us or we come out to meet with a patient, we can finalize the document and notarize it all in one fell swoop. Two of the biggest barriers that I notice when I meet with clients are the agent and the signing in front of the notary. Now, unlike an advanced healthcare directive where you can kind of lay out your personal wishes and elect to name an agent, for a power of attorney, you have to name an agent. The document essentially functions like a permission slip. So if you don't have somebody that you can kind of point to, this is my agent, the document really doesn't do a whole lot. So this can bring up a whole myriad of different feelings with people. Some people don't have someone in their life, which can make them feel overwhelmed and sad, ashamed. And And we try to be very clear, like that is not a unique problem. This is something that people come across. Have you considered going to, maybe this group, or you connect them with somebody in our office who might have a connection to a Shanti support group. So there are ways to kind of operate around that, but that can bring up a lot of uncomfortable feelings for patients and clients. Unfortunately, if they cannot come up with someone that they want to name, we can't execute the document for them. But we always let them know we're available. If you meet someone, if you come across someone, if you repair a relationship with a family member, let us know and we can come back out and we can execute this for you. The one thing we advise against, if a client says, oh, well, I met my next door neighbor 2 weeks ago, they seem super nice. That's wonderful. This document is incredibly important because you are essentially conveying to someone else a fair amount of power over your finances and legal decision-making. So you really want to make sure that you trust that person. So I would rather you pick somebody that you trust a lot, even if maybe they don't live in San Francisco, rather than someone who maybe lives next door and you think they're kind of just okay. You really, really, really want to trust that person. And so it's important that the client recognizes sort of the gravity of the power that they're conveying to their agent. The other barrier that we occasionally run into is signing the document in front of a notary. So as a notary, I have to see a valid ID to execute my notary stamp. Sometimes when folks are in the hospital, they don't know where their ID has gone, or maybe they stuck it in a bag and they kind of have forgotten, or they didn't take it from their house, or it's expired. So there are ways around that. But in order to execute this, the document has to be notarized. And the most straightforward way to do that is having a valid government ID, like a city ID, driver's license, or a passport. Again, if not, there are sort of workarounds, but it can take a little bit longer to get that done. Now, when is a power of attorney valid? It depends on the desire of the principal. So if the principal says, you know what, as soon as this document is signed and notarized, I want this to be valid, meaning that person's agent could take the power of attorney and walk to the bank and say, hey, I'm Emily's power of attorney. I want to take out some money. And they could do that, which is why it's so important that you trust the person that you're appointing as your agent. Now, you also have the option of having the power of attorney go into effect only when a doctor has deemed that you have lost the proper capacity to operate on your own. And so a lot of folks I meet with just feel personally that they don't want to relinquish this kind of financial power right away. And so what would happen in practice is if the document is only designed to become valid once you have lost the capacity to make your decisions, your agent would have to take your power of attorney, as well as a letter from your doctor confirming that you have lost capacity, and then bring that to the financial institution in order to act on that document. Now, that's typically called a springing power of attorney, meaning it sort of springs into effect once you've lost the capacity to function independently. Another version of a power of attorney is one called a durable power of attorney. And that basically means it's designed to carry on once you become incapacitated. And so occasionally these phrases are used interchangeably, but there are actual sort of legal guidelines behind the different sort of versions of powers of attorney. Now, talking a little more about an agent, who can act as an agent and what can they do? So any adult over the age of 18 who is also of sound mind, who is not incapacitated or incarcerated, can act as your agent. Now, again, there's no requirement that that agent be local or a spouse or relative. To me, the biggest priority is that you trust them. That needs to be the highest, I think, standard. They can live in Timbuktu. Oh, yeah.
Is there an issue around citizenship?
That's a good question. You can appoint someone outside of the country, I believe, but you need to think about kind of the logistical challenges behind that. Because if you need someone to run to the bank on your behalf, if they live outside of the country, that's going to create some logistical problems. That is a heavier topic than I probably can undertake, but yeah, I mean, I think it would be up to the agent whether they're comfortable being appointed, but yeah, they'd have to present IDs, things like that. Yeah. Oh, for sure. Yeah. The owl. The question was more, can you appoint someone to be your agent if there's concerns about citizenship, given kind of the uncertain political climate right now? And I think that's a valid question.
But in general, a non-citizen, if they live in the same city.
Should be fine, yeah. Now, again, the agent will have authority to make financial and legal decisions if the principal is unable to do so or if the principal needs support. So if you are lucky enough to have multiple people in your life that you trust this way, you can appoint up to 3 agents to act, and they can either act together as sort of one team or independently. So if not 1, then 2, if not 2, then 3. And then what steps should I take once a power of attorney is complete? Once it's complete, signed and notarized, the principal, so the person who's made the document, should keep the original and then give copies to the agent. It's written within the document that a copy should have the same force and effect of the original document. And so if your agent only has the copy, that should be sufficient to be able to still act on your behalf. Now, the client can revoke their power of attorney, change their agent, change the power that they've given their agent at any point in time. That is one thing that I try to emphasize a lot when I meet with clients is this does not have to be set in stone unless you want it to be. If you reconnect with a family member, if you lose contact with your agent, make these changes, call me, that is okay. I'd rather you guys have documents in place that sort of really align with your wishes. And then how does ALRP support? So again, our organization's been around for a long time. We are, I think there's 10 attorneys on staff. We provide support in estate planning. We do simple wills, advanced healthcare directives, powers of attorney, and we're beginning to do some trust work in-house. We provide support through appointments in our office. We provide support at hospitals, at homes. We try not to limit where we're able to go to support clients of ours with these documents because they are so incredibly important. And as far as completing a power of attorney, it can take about 10 minutes to actually write it out, another maybe 10 for the notary. So start to finish, it can be about a half an hour to a couple of weeks because there can be an emotional component that come along with that kind of decision because sometimes they can't find their ID. So usually we'll start with a phone call. I'll explain a little bit about, kind of what's going on, what they need to consider, and then a follow-up appointment to actually draft the document. But if necessary, we do emergency appointments often where I will hop in a car and come down to the hospital and get a document done in an afternoon. So it can range, but usually takes about 30 minutes to an appointment or 2. Now, if you have patients that need support with these services, with other ALRP services, the best way to refer to our office is calling the intake line, or you can submit a web request on our website. If you have other specific questions about what I talked about today, or just have questions about the referral process generally, you're welcome to reach out to me. My email address, I'm so sorry, could not be smaller. That was my fault on the font. But please feel free to reach out to me. I'm happy to answer any questions, and I will hand it off to Hannah.
I want to start with all my questions for you. That was really good and super helpful and interesting. Thank you so much. Okay, so I'm Anna Chodos, and I'm going to present our second case. And I think we should have lots of time for questions, which is great. So get them ready. So I'm going to go over our second case, which is a 70-year-old man. I swear this is, I think, half of his problems on his problem list. But I wanted to represent some of the things we were tackling in clinic. And this was, Meredith saw this patient, and I really was so impressed with, as I always am, with the primary care workup that was going on and how much was being juggled with this patient. But main things, of course, he's living with HIV, he has dementia. This was something Meredith mentioned, we're calling mild cognitive impairment and dementia now minor neurocognitive disorder and major neurocognitive disorder. I'm just saying that because you might start seeing these terms and these codes. But so he has dementia already, has that diagnosed, COPD, CAD, CKD, diabetes with peripheral neuropathy. He also has significant cervical spinal stenosis and has a pretty severe gait disorder with mobility impairment. He's had recurrent falls, some requiring hospitalization. He's living with chronic pain. He has sensorineural hearing loss, depression, prior strokes or cerebrovascular accidents, hidradenitis suppurativa, and pressure ulcers in his lower, like his buttocks and sort of back area. He has an alcohol use disorder, but at the time of this visit had been sober, very proudly so, for about 9 months. And he's here for follow-up for geriatric assessment. He'd been seen previously by prior Meredith, Dr. Green. And he's also, one management thing that has come up is some behaviors related to his dementia and possibly other things. So this is sort of the scenario and his general living situation. And this was pretty interesting to me. One of those charts you read and you're like, would love to know more and really meet this person. But lives with a roommate. So he had been intermittently housed, living at Maitri at one point, discharged or asked to leave because of behaviors, and ended up living with somebody who was willing to live with him and be his roommate and IHSS caregiver. So he has IHSS in-home supportive services in place, which is support for functional disability, like shopping, cleaning, personal care. He has health at home, which is skilled services that come to your home, but this is intermittent. Of course, this is a goal-based service, but that is one support that clearly the team is really relying on to help him thrive in the community. There is an issue, there's an ongoing attempt to refer him to what we call adult day health and get him supported with that service. And he has a payee to manage his finances. And that's sort of, I always think of that as sort of like an interim move between a durable power for finances and no one and yourself. So just want to give you a little more flavor of what his behaviors are. We're going to get back to these at the end, but one key one is refusing. So he refuses a lot of care from the caregiver and also refuses a lot of his medications or just doesn't take them. So, but he'll take the ones that he knows are essentially important to keep him out of the hospital and to keep him treated with regard to his HIV. So he'll take his insulin, he takes his HIV medication, and he's willing to take his pain medication for his symptoms. His IHSS caregiver also says he's just very unmotivated, doesn't want to do a lot during the day, very hard to get him motivated around self-care, but also just any activities. The caregiver also reports that he's intermittently very verbally abusive and even occasionally seems to threaten physical abuse, has not carried that out, but has sort of, attempted to swing at them when they've tried to help him with his self-care. Okay, so that's mostly background. Now, today he comes in, he's saying his memory decline is ongoing. It's worse. In my view, in my estimation, that would be expected. So if you have dementia, that's not necessarily unexpected. But he's also, this is a good example, he's reporting independence in his self-care, but then the caregiver says, actually, he needs my help for almost everything. So this is often a scenario we see, particularly with people with dementia, where we're gonna get collateral information, of course, about how they're doing. They report that part of his motivation, for example, but also just his mood, it seems like he has worsening depression, although he doesn't necessarily outwardly endorse that. And then the caregiver also seems overwhelmed in the assessment. And of course, reporting this abuse has sort of indicated that they're overwhelmed with how to manage this. The other major thing that happened, he just had a fall, broke a tooth, but no other loss of consciousness or major notable head injury or injury. Has ongoing issues with insomnia and constipation. Some of the clinical evaluations showed he's now at this point using a wheelchair. He's in the process of getting a mechanized wheelchair for ambulation. He had a repeat MOCA, so hats off to the team. I think the nurse was able to complete a MOCA, and he got a 19 out of 30, which is somewhat abnormal. A normal score is 26 and above. He scored 8 out of 15, which on the geriatric depression screen or scale, which is indicative of mild or moderate symptoms. So what we're going to talk about with him is actually, the first thing we're going to talk about is his medications. So this is his medication list, pretty standard, I'm sure, for many patients of his age and with his comorbidities. And I just sort of want you to take it in, start having your thoughts about these medications. How would you approach it? How would you want to support him in optimizing his medication management? Of course, we know he doesn't really like to take most of these, but they're on his list. And we hope occasionally magically getting into his body. Okay. So we've thoroughly appreciated his medication list. And again, we hear from his roommate that he doesn't really take his medications. And then Health at Home that has initiated has said that when they come, a lot of pills are on the floor. It seems he does mostly not take his medications. I think we decided to leave questions to the end so you can sort of mentally jot down your thoughts, and we'll talk about them when we get to a med rec. But I'm going to ask a question first. So I don't know if you guys use any resources for deprescribing. There's increasing ones out there. We use the term deprescribing to mean obviously stopping medications, but also sort of improving or optimizing medication management for that patient's goals. So we have some resources out there, and one of them is Real. So I just want you to pick the real one. So there's the Tipsy Tips Toolkit, which is a deprescribing guide for reducing potentially harmful medications in patients with falls in the community. There's Less Sedatives for Your Relatives, a toolkit for reducing inappropriate use of benzos and sedative hypnotics among adults in hospitals. There's Oh No Opioids, an algorithm for safely reducing opioid use for chronic pain in adults 60 and older. And then there's the Guinness Guide, an evidence-based compendium of criteria on potentially inappropriate medication use in older adults. So which one do you think is real? We wish they were all real, but oh, I like that, the Guinness Guide. I guess, like, how corny do you think polypharmacy enthusiasts are? Yeah, I know. I'm definitely partial to starting to get working on letter C. Sorry. Actually, Less Sedatives for Your Relatives is real. It's an effort by Choosing Wisely Canada. We're hoping increasingly hospitable neighbors to the north. But this is just to point out there's, I think better and better resources all the time for deprescribing. And I want to acknowledge that in general, I know for me, it's always a challenge, right? Because we're really trying to balance evidence-based care, making sure we're optimizing treatment and meeting all the guidelines, but then also we have these patients who do what they will and have other goals. One good resource is deprescribing.org, very evidence-based, and they do a lot of trials on what works. They've done a lot of like community pharmacy-based interventions on education and supporting people to learn more about their medications and reduce them. Sorry, I couldn't get this to be darker, like the image, but basically I just wanted to let you know that right now, these are algorithms that they have for deprescribing. So PPIs, anti-hyperglycemics, antipsychotics, benzos, and cholinesterase inhibitors and memantine. This is all focused on older adults. So just a resource I wanted to make you aware of. There's not the Guinness Guide, but there is the beers list. So I was seeing if I could ring any bells in people's minds. But the beers list we talk about all the time. It comes out, gets updated every few years. It's put out by the American Geriatric Society. It can be a little sometimes challenging to find the full PDF. That's probably a good thing because it's very comprehensive. So every possible medication that has any potentially inappropriate side effects in older adults is on there. The one nice thing about it is it does include some information about comorbidities and medications that may be contraindicated with certain chronic conditions. But this is sort of, for better lack of a term, sort of like our Bible around deprescribing and polypharmacy in older adults. But sometimes, and I've certainly experienced this myself, can be challenging to implement in IRL with the sort of comprehensive nature of the resource. But it is an important one. But I just wanted to go over some practical deprescribing tips. And since you've all made your mental notes about our gentleman and sort of what he's working with his medications and what his primary and what the geriatrics clinic is and the pharmacist is supporting him with. So really the first thing, we can't always get it, but we really try to start from a place of really understanding how this person's taking their medications and what they're really taking. I think there was a study done out of the VA, like particularly post-discharge, that showed that 100% of the time medication lists are wrong. And it can be something silly like the eye drops aren't in there or whatever, but we're all aware that medication lists are a starting place for a general understanding of what the person's taking, but often rarely reflects their true medication regimen. So these are sort of the four things I always keep in mind. The first and typically the most important to me is there something that we know is really problematic for older people and they shouldn't be on? So we know cause serious adverse side effects. That may be, particularly an overtreatment of a condition like hypertension or diabetes in a particularly frail or somebody with a life-limited illness. But then often we're dealing also with sedating or cognitively impairing medications. The big one here that we often think about sedatives and hypnotics, but then there's also sort of the realm of the anticholinergics. So often in dementia clinic or geriatrics clinic, we just review meds to see which have cholinergic properties. I often use this thing called ACB Calc, and that gives me a score with their whole med list of how anticholinergic their total package is. Or I can just double check a certain medication. And it's very clear we try to get people under a score of 3, and that has to do with dose type of medication in terms of how sort of anticholinergic their day-to-day life is on the medications we prescribed. Then I always look to see, does every medication have an indication? And what was beautiful about this particular patient's notes and everything was they were all sort of problem list based. And so every problem sort of listed out the medications underneath. So I think that obviously for a lot of us is a helpful way to keep track of, I'm actually prescribing something for a condition and it's sort of not just floating around. You'd be surprised. I know it sounds like, how could that happen? But you'd be surprised. And then I always, there's a principle in geriatrics of really ensuring that every medication is truly doing something helpful, but not helpful in the theoretical, like meaningfully helpful. Is it treating a symptom? Is it really, risk reducing in a way that helps meet this person's goals? Because we have so many guidelines, so many things to treat, but is it really helping this person? And then the counterbalance to that is if it's hanging around and it's not really having a big impact, it's only hurting the person. It's only going inside their body to cause a problem if it's really not helping them. So we really want to know we're getting benefit. I think the clearest example of this is really the dementia medications that we have right now. Most of them help a tiny bit with symptoms in a tiny percentage of people who have dementia. And wonderful if you're that person, then we have a meaningful impact that we're seeing with this medication. But for a lot of people, they just hang around and it's out there out of some sort of collective guilt of medicine of not having effective medications for this condition. So that's something we want to take away if it's not clearly improving that person's life. We also know that polypharmacy just in general is harmful. So doesn't matter what they are, the more meds that are on your list, the more likely you are to fall, to have a functional decline, to have weight loss and difficulty eating. So, and it has something to do with reducing saliva and other things. So somehow the more medications we pile on, the more complications we cause. So we really want to get it down, thinking about getting it down to the most meaningful, smallest and most appropriate medication list. And then sort of the last sort of tune-up moment I always think about is every medication at the optimal dose and frequency? Is there a way we can simplify how often they're taking it or reduce dose? So even if we're reducing dose, we're reducing polypharmacy. So then there's a cadence issue, and we could think about this with this patient. I've seen different approaches, and of course, different patients need different approaches. But are we just going to do a slash and burn? Are we going to go from 12 to 4 medications today? Or are we going to make small improvements, see how we go, see you frequently, support you through that? And again, you guys have an amazing clinic with pharmacists and all this support. So it's really, you're in a great situation to do that. But I will say, and I think about this all the time, our older patients really don't have as much time to waste on refining their medications and improving their lives. So let's get to work. So slash and burn, not a terrible idea. So this guy, when I was thinking about his medication list, the first thing my mind usually does is I start to group into indication or why they're taking them. What benefit are they getting? So this is sort of how my mind started to lump them together. And like I said, I think we're holding things to the end, but definitely towards the end of this list on the right side, I'm seeing some things on the bottom that I'm wondering if they're really doing very much. Of course, they could do something if he took them, but if getting any medication into him is a challenge, these may not be the highest yield. We know that the pain and muscle spasm medications may be for him the most that he's focused on. I'm very grateful he's continuing to take his Biktarvy. But then, if he's only taking insulin Why is he still on metformin? Sorry, I'm sort of jumping around here. I hope you can follow. And then his antihypertensives. I will say in every visit, he was very hypertensive. He's had a stroke. This is not a good feeling for anybody. But the benefit we may get from removing some of the medications that he's not taking and stopping to put them in his Mediset or his bubble pack or however we're trying to simplify things for him, we may start to see that he can take one more really crucial medicine like an antihypertensive. Again, then the last thing I'm usually doing, so we've lumped by indication. We're looking for the highest risk meds. Actually, I didn't mention that. We're looking for anything that we can sort of dose reduce or optimize. And the main one there is the only one that really jumps out to me is the escitalopram, which is a little highly dosed for an older person. We usually keep that at 10 milligrams or less. And then the gabapentin is really right on that cusp, and particularly somebody with cognitive impairment and dementia. It may be really making him very drowsy, although of course he reports insomnia. Obviously, we're wondering about the cyclobenzaprine and oxycodone as well. Kind of what's our strategy with this? The oxycodone particularly may be safe if he's able to manage it and he's, really, really needs that for pain control, but it would be something to watch very carefully. And then probably the cyclobenzaprine, we really want to interrogate with him how helpful that's been, because that has a lot of sedating and cognitive side effects as well. Keep in mind your questions if you think I've missed something. That was kind of an overview. So this was after the last geriatrics visit, but he did have a potential overdose. He had an incident where he was found really difficult to arouse, and so his caregiver had to call 911. At the time, he was also drinking alcohol, so when he was sort of better able to describe what happened, he said he thinks he just drank too much in the context of also taking his pain medication. He didn't think he wasn't trying to overdose, and he didn't think he needed to go down in any way, that this was unfortunately due to the combination with alcohol. But I think the other thing that comes into play here is his cognitive impairment, and again, simplifying in the context of that. So when somebody has a diagnosis of dementia, that's sort of another reason I'm really trying to just slash and burn their medication list to the most essential medications. I just want to point out some additional thoughts that I had, and one, I guess I got ahead of myself on the last slide, but he may not be a great candidate. He does have COPD. I'm not sure how complex his respiratory status is, but he may be a candidate for trying buprenorphine for pain management, particularly if he's intermittently not able to manage the oxycodone safely. However, his PCP had assessed this pretty carefully and thought, with like extensive conversations with the caregiver, that he was being monitored much more closely around this. So obviously, though, this is a really important medication to have some additional stopgaps on. Okay, so I was going to move into just a brief discussion of also what's going on with his behavior and one way we can think about improving behavior. That is, a 4-hour talk on its own to really feel super duper comfortable with the issues around behavior management and dementia. But I think we couldn't help it. We wanted to put a plug in for Adult Day Health, which probably many of you are very familiar with. So they've been trying to connect him forever. I have just on a vibes based kind of assessment, I have a feeling it's not going to happen. He's not going to make it to Adult Day Health, but it's a wonderful idea and worth continuing to try. I think a good principle in behavior management, if somebody's refusing or amotivated around a new idea or new program or some sort of behavior change, is just keep trying. It's one day you may capture them when they're feeling really motivated and willing to try. We do have some wonderful Adult Day Health programs. These are Medi-Cal funded programs that provide skilled needs, RN, OT, PT. The ideal candidate is somebody who does have some ADL, activities of daily living impairment, because this is for people at risk of institutionalization to delay that. And it provides transportation. The one big caveat here is that person has to be cognitively well enough or have a caregiver who can get them to the van. So the van won't come up and help them get into the transportation. So that can be a limitation for some of our folks. A plug-in as well for the Unlock Open House collaboration on Adult Day Health Program, Club 75, a very fun group. And some additional tips that I think are really, really highlighted in this case is we really struggle in clinical primary care to treat dementia behaviors. The reason for this is because it's really a education and support-based intervention for the caregiver. Managing dementia behaviors is really a day-to-day activity in the home when the behaviors are happening, and that can be a really hard thing for us in primary care to treat, obviously, with medication. And I know it's taken me a very long time to feel comfortable really walking caregivers through what they're going to need to learn and how they're going to need to get support. But one of the biggest things we can do, even if we don't really feel comfortable walking through all the interventions that are out there or all the supports that are out there for caregivers and how they can get more support to know how to manage behaviors in the moment, is respite. And adult day health is one of those things we really lump in the category of caregiver respite, because it gives that caregiver time during the day to simply recoup and sort of refresh their batteries. So we're always looking for opportunities, especially when there's verbal or physical abuse or other really, really challenging behaviors that we're obviously looking also to stop and to manage. Respite can be a lifesaver. Other really big principles are, when I talk to caregivers, is learning about how to de-escalate the situation with redirection and reassurance to the person. People tend to respond much more emotionally than to verbal conversations about why the behavior is not appropriate. Routine, safe, familiar environments really help maintain manageable behaviors, and then making sure that person has basic needs met. I sort of repeatedly, I'm a complete and total broken record with caregivers about making sure to explore the resources that are out there for them and just do such a better job. Caregiver.org, which is the Family Caregiver Alliance, and Alzheimer's.org. It's this sort of absurd scenario where literally millions of people are going through the exact same thing every day, completely alone. And what these organizations really try to do is bring the peer support into the equation and make it really accessible. And when I do have caregivers who have the time, the ability, and the interest in joining these, it's 1,000 times better than any advice or handout I have for them. One example, A Place for Mom, just to put it out there, has sort of tips that I think are really accessible for people to sort of start to approach the issue of behavior management. So when people are aggressive, you actually almost sort of paradoxically turn to reassuring them, making sure they feel like they're in a comfortable environment, that something isn't scary or intimidating, and then distracting them by helping them connect to something they really like to talk about. Okay, so the last one is, we went over it really briefly, and we're almost here at the wrap up. Adult Day Health provides medication management at the center, emergency respite to people's caregivers in the home, or massage services, in which case we're all signing up for Adult Day Health. Thank you so much. I wish it provided emergency respite to people's caregivers in the home. It is able to provide medication management at the center, and obviously it doesn't provide massage services in any sort of formal way. So the services there include really self-supervision. They have a nurse to do health monitoring, med management, meal, snacks, and transportation. And then they do provide some social services towards the caregiver and help them connect. So we can also think of it as an extension of our ability to do that with our social work teams. This is an additional resource for caregivers. But right now, I don't believe they're able to provide emergency respite at home. They might be able to connect to a service. Our main service for local resources is, of course, DAS, Disability and Aging Services at DAS, and these are some of the Adult Day Health programs. And then just a plug for PACE for he might be a great PACE candidate if he remains housed. He's going through a housing switch right now, and looking at an RCFE. But PACE is sort of Adult Day Health plus the medical, all integrated, as we know. So we're thinking about, we have Unlock in the community. Now we have NEMS. NEMS has, particularly for Asian language speakers, has a new PACE program. Just want to make you all aware, for people who have a dementia diagnosis and Medicare, In July, we're starting a care coordination program. So, and this actually does come with like a whiff, just a whiff, but it's there, of an annual in-home respite benefit that we can bill Medicare for. So they can get probably a couple days worth of emergency respite in the home for the caregiver. And they will have home-based services like training on skills, caregiver skills in the home through this program. I'll be sending out an email so that you guys know more about it and know how to refer. We're going to call this Dementia Care Aware San Francisco. We already have a pool. You're welcome to tag people you think are great candidates now. The only bummer is they do need to have Medicare. So for some of our folks who don't, we still need to work on a program and a way to fund that. So key takeaways, which we've already talked about, and I'll summarize for my colleagues. Advanced care planning, both healthcare powers of attorney, legal powers of attorney are really important. We have this amazing resource and Emily's email. And we have special considerations for medication management and polypharmacy for older adults. And you guys have geriatricians and pharmacists to help. And please think of adult day health or other resources in the community as a way to provide respite for caregivers. Thank you. We do have a few minutes for questions.
Thank you so much. That was excellent. Question.
Are there any online?
Nothing online yet.
This is a question for ALRP. Are you overwhelmed with issues about what's going on with the administration and legal challenges to dismantling HIV prevention or NIH or any of that? Or is that part of what you're involved, like with AVAC and other AIDS organizations? Given your lawyer expertise, there's a lot to do.
I think like most folks who are dealing with HIV cases, yeah, we are overwhelmed by that, just sort of more like generally in our office of like, what does that mean for our ability to care for our clients? As far as the actual like boots on the ground funding sort of work, we have a few folks in the office who go to the town halls, who try to advocate for additional HIV funding, explain kind of how that impacts our office as a whole. But as far as our actual like legal work in-house, the biggest jump we have noticed is concerns with immigration. And so while yes, we are all concerned, all globally concerned about how these cuts to funding can impact our ability to serve our clients, we're not actually doing any kind of like boots on the ground as an office work outside of a few folks in our office who go to the mayor's office, go to budget meetings, advocate through the HIV and AIDS happen, HIV. Thank you very much. So many acronyms. So anyway, yeah, in short, the actual legal work that's mostly impacted by this shift in administration has been immigration, but we are very, very aware of how the impact of funding could impact our work.
All right. Thank you so much. All right. Have a good day. Thank you.